is going to be talking about how effective is prior infection and vaccination, so hybrid immunity on clinical outcomes. And then we will have Professor Katie Flanagan looking at the immunological perspective, so the differences in immunity in people who are vaccinated but not infected and those with hybrid immunity. And then we'll open for discussion later on. And so I'd encourage you to put your questions in the chat or the Q&A, and I will read them out at the end, but we should have quite a long time to be able to discuss those questions. So I'm going to hand over. So first of all, the session will be recorded, and so we'll be able to post it onto the website later on, and also Audrey may be in contact with you about the recording sort of later on, and if you prefer not to, then just contact Audrey, and there's her email there. So our two speakers today are Professor Katie Flanagan, who is the Head of Infectious Diseases at Launceston General Hospital. She's Director of the Tasmanian Vaccine Trial Centre. She's a clinical professor at the University of Tasmania, and also adjunct professor at RMIT. She's also the president of the Australian Society of Infectious Diseases and a member of ATAGI. And so, and firstly, we'll be having Dr. Niklas Bobrovitz, who's a research lead of SeroTracker, which is at the O'Brien Institute of Public Health at the University of Calgary in Canada. He's also a research associate in the Department of Critical Care Medicine at the University of Calgary, and he's also a medical student at the University of Toronto. And so Niklas was the lead in a systematic review for WHO SAGE on the vaccine, the effectiveness of hybrid immunity on clinical outcomes again. So I'll first hand it over to Niklas for your presentation. Thank you very much, Niklas.
Thank you so much. I will just share my slides here. Can you see those slides okay?
Yep, looks great. Thank you.
Perfect. Okay, well, thank you so much for organizing this webinar and for inviting me. I'll share the results of a systematic review and a meta-regression looking at the protection provided by prior infection and hybrid immunity. So, the initial questions around protection from COVID focused on vaccination, and in particular, comparing vaccination to people who are immune naive. People wanted to know how much protection does the vaccine offer, how long does that protection last, when a person should get vaccinated, and how many vaccines they should get. Some colleagues at WHO did some great evidence synthesis to answer those questions. You can see here the results of their two reviews, one in Lancet and one in Lancet Infectious Disease, and they focused on that vaccination versus immune naive comparison. Unfortunately, many people have been infected though, and those prior infections introduce new questions about levels of protection in the population, and answering those questions requires a few different types of analyses. So, the questions now are, how much protection do I have if I've been infected? How much protection do I have if I've been infected and vaccinated, which is hybrid immunity? If I've been infected, is there still benefit to getting vaccinated? And if you have this hybrid immunity, what's the value of getting additional vaccinations? So these are the types of questions and the types of comparisons that we hope to address in our systematic review. So I'll just very briefly walk through some of the methods of the review. Our goal is to estimate the magnitude of protection against Omicron infection and Omicron-caused hospitalization and severe disease at 1 month intervals, and also to evaluate the changes in protection over time. We also wanted to compare our estimates for prior infection and hybrid immunity to those previous vaccine effectiveness estimates that I just mentioned, which were produced by colleagues at WHO. So there's a quick summary of our methods of searching. The searches ended on the 1st of June. There's the list of sources that we evaluated. We included randomized controlled trials and controlled observational studies, although we didn't find any relevant RCTs for inclusion. And we evaluated risk of bias using the Robbins I tool. You can see on the right-hand side there the different types of comparisons that we did. So the estimates of protective effectiveness are sort of considered like absolute levels of protection because they're compared to people who are immune naive. And then there's a set of comparative protective effectiveness estimates where the baseline group has some level of protection existing already. Two key things to note here. When we talk about prior infection, all the evidence so far is for pre-Omicron variants only. There is, new emerging evidence looking at Omicron prior infection and Omicron subsequent infection, but we haven't yet analyzed that data. And when I talk about booster vaccinations, it's first boosters only. The literature hasn't quite caught up yet with second boosters. So don't pay too much attention to this slide. This is just for the statisticians in the crowd. A couple of key things to pull out from how we did the analysis though. So we used meta-regression. When I talk about protection at different points in time, for prior infection, we count from when the last infection was. For hybrid immunity, we count from whatever the last challenge to the immune system was. So it could have been an infection or it could have been a vaccination, whichever was most recent. The outcomes were any infections and hospitalizations or severe disease. And we did a sensitivity analysis where we excluded hospitalization. As you know, Omicron was very prevalent, and there was, many instances where people were admitted to hospital and found to have sort of incidental COVID infections on top of whatever their presenting complaint was. So we wanted to exclude those in a sensitivity analysis just to see what that more pure measure of severe disease was. So we'll walk through the results now. We included 11 studies on prior infection and 15 studies on hybrid immunity. And you can see the summary of the study characteristics there. So the sample sizes were quite large overall, and there was quite a large number of estimates in each category. And the categories are organized here by the same comparisons that I showed you earlier. So prior infection versus immune naive, hybrid immunity versus immune naive, and so on. And most of the estimates were moderate or serious risk of bias. So there were no critical risk of bias, which is good. Unfortunately, there was also no low risk of bias. So sort of middle of the road in terms of the trustworthiness of the evidence. This is a summary of the different vaccines that were used in the hybrid immunity studies. So there was 5 different vaccines used: the Sinovac, Pfizer, Moderna, AstraZeneca, and the Johnson & Johnson. There's also a mixed vaccine category, which could include either individuals who received different, primary series and different boosters, or, combinations of groups of people, some who received mRNA, some who received Johnson & Johnson. So now we'll walk through the protection estimates. So this slide shows the protection conferred by prior infection relative to being immune naive. You can see on the left the graph showing protection estimates over time. The top graph shows hospitalization and severe disease. The bottom graph shows any infection. And the table on the right just shows the numeric estimates from the graphs. So you can see in the top figure, protection against hospitalization or severe disease is fairly high, and it remains, stable over time. So at 12 months after the last infection, a person has about 75% protection remaining. When we look at any infection, you can see that there's a fairly significant wane over time, so that by 12 months, you only have about 25% protection left against any infections. And the sensitivity analysis, which excluded hospitalizations, showed even greater protection against severe disease. This slide shows the same layout overall. These are the estimates of protection for hybrid immunity with a primary series. You can see for hospitalization, severe disease, even more protection and sustained over time as well, and a similar pattern with any infection. Not quite as significant a decline, but still, a fairly rapid wane. By 12 months, protection against severe disease is over 97%, and against any infection, it sits at 42%. This shows the next level up, so hybrid immunity with a first booster. And the data aren't, the follow-up times aren't as long yet, just by the nature of, when the first boosters were rolled out, but very similar findings as the hybrid immunity with primary series. So high levels of protection against hospitalization and severe disease, sustained up till 6 months, and a fairly rapid wane against any infection. So this is just the last 3 slides combined, just to give you a general sense of what the levels of protection over time look like for these different types of immunity status. And this slide uses the data from the last slide I just showed you and adds in the vaccine effectiveness data from our WHO colleagues. So you can see the 2 graphs there, hospitalization or severe disease on the left, any infection on the right, and these are estimates of protection over time again. The green line is prior infection compared to immune naive. The blue lines are hybrid immunity, so infection and primary series and infection and first booster compared to immune naive. And then the orange and red lines, those are from the WHO folks. Those are the vaccine effectiveness estimates for primary series and for first boosters. And the table on the right compares estimates of protection at 6 months. So you can see for hospitalization and severe disease, hybrid immunity has a superior level of protection at 6 months relative to vaccination only and relative to prior infection. When we look at any infection, again, hybrid immunity is superior relative to vaccine only, but not significantly better than prior infection. Now, these are indirect comparisons, and there's some limitations to that. So these use, studies looking at immune naive versus prior infection and comparing them to estimates looking at immune naive and hybrid immunity. In general, the studies were fairly comparable, but they are indirect comparisons. So I'll show you a few of the direct comparisons we also looked at to sort of verify some of these findings. This slide shows a direct comparison between hybrid immunity and prior infection. So the study gathered a sample of individuals and compared people who had prior infection to people with hybrid immunity. And they showed that there was significant benefit to having vaccination if you've had a prior infection. So you can see the top 3 rows of the table show outcomes for hospitalization or severe disease, for hybrid immunity with primary series, full primary series, and partial primary, full primary, and the first booster. And you can see the estimates of protection on the right. And for the bottom 3 rows, protection against any infection. Again, for hybrid with partial primary series, hybrid with full primary series, and hybrid with first booster. So you can see there's slightly better protection against hospitalization, severe disease, but overall hybrid immunity is better than prior infection. This slide shows a comparison of people with hybrid immunity and more vaccine doses compared to people with hybrid immunity and less vaccine doses. So this tells you whether there's added value to providing additional vaccination in somebody who already has hybrid immunity. And again, you can see the top 3 rows there show hospitalization, severe disease, and the bottom 3 show any infection, and the estimates of protection are on the right. Now, there was a little bit limited data for some of the comparisons, but significant increases in protection with the greater number of vaccinations. So it would be really nice if we had this data stratified by age. A lot of the vaccine policies, are dictated by age range. Unfortunately, few studies actually reported age stratified data for us to use. And of the ones that did, there was, really no consistent finding to draw a conclusion from. So this is a pretty significant gap in data that investigators looking at these types of studies or conducting these types of studies need to address. The age stratified data are necessary. So in terms of limitations to the review, a few of the key analysis we were hoping to do were not possible because of the lack of data or because of heterogeneity in some of the reporting. So like I said, the stratifications by age weren't possible, but we were also hoping to stratify by sex and by the severity of the index infection. That wasn't possible. We were hoping to look at the sequence and the timing of the vaccinations and the prior infection for hybrid immunity. A lot of these studies do actually report that information, but there's so many different combinations and permutations that it's, you're left with very limited data within each category, and there's not a lot to actually analyze or to pool together in meta-analysis. And finally, the next step of this will be looking at an index infection with Omicron and how much that protects you against future Omicron infection. So far, this data is only for pre-Omicron index infection. And as I mentioned, actually I hadn't mentioned this yet, but in terms of the risk of bias, so most studies were fairly good, moderate risk of bias, although some were at severe risk of bias, primarily due to lack of adjustment for confounding. So adjustment for comorbidity, calendar time, and testing frequency would help, increase the trustworthiness of some of the data. And in particular, for time, it would be really great if we could adjust for time since each immunity challenge. Now that's maybe unrealistic, just given the limitations of data collection, but that's an important question to answer. Currently, when studies adjust for time, they're usually just adjusting for time since the last immunological challenge. So in terms of just a summary of what we found, prior infection and hybrid immunity both provide greater and more sustained protection than against Omicron than vaccination alone. Protection remains high for hospitalization and severe disease, but wanes fairly quickly against all infection. And individuals with hybrid immunity had the most superior protection for all outcomes. In terms of recommendations, I think the conclusions here are, even if you've had a prior infection, you still need to get vaccinated. Although hybrid immunity and prior infection, appear to be provide better protection than vaccination only, no one should get purposely infected with COVID. You could die, you could end up in the ICU, you could have long COVID, or end up with one of the many terrible neurologic or cardiac complications. For people who do have hybrid immunity, in particular people with prior infection and full primary series, it might be reasonable to delay the boosters for 6 months because the level of protection is so high and sustained that you're not at a ton of risk at that time. And even a longer delay up to 12 months might be reasonable without losing protection against severe disease. That sort of delay might not be reasonable in people who are high risk though, so the elderly and the immune compromised. And in particular, because we weren't able to stratify that by that data, so the levels of protection in those groups are unknown. And finally, given the wane of protection for all types of immunity against any infection, mass vaccinations, timing them for a rollout right before increased incidence of increased expected levels of incidence would be reasonable. So similar to a flu vaccine strategy, before the winter season, having a push for vaccination might help reduce some of the infection rates. So thank you very much to the team who made this possible and for the organizers of the webinar today.
Fantastic. Thanks so much for that, Niklas. I'm going to go next. So Audrey, I've had some problems with my slides. So Audrey's going to share my slides and move them for me. So Audrey, if you could pull up my slides. So great. So next slide. So just a reminder as to what Niklas has already said. So hybrid immunity is derived from infection and one or more vaccine doses. And so what we're talking about is really population level immunity sort of today. And then next, Audrey. And it's not a public health strategy, but it's an epidemiological situation. So again, just reiterating what Niklas has said, it's not that people should go out and deliberately get themselves infected for all the reasons that Niklas has listed. Next slide. So I'm going to just go through some of the surveillance data from many of the countries to show sort of examples from the surveillance data, examples of hybrid immunity and sort of what we're talking about. So South Africa is probably a classic example. They've got very good surveillance. And on the left here is the incidence of hospitalizations, COVID hospitalizations by age group. And this is throughout the whole pandemic period. And so the largest peak there is around it was around early 2021, and then the next peak is Delta and then Omicron after that. And on the right hand side is the deaths, and you can see that with each wave that there's declining severity. Now South Africa has had about 300,000 deaths. So this has come at an enormous cost, and a lot of those deaths sort of occurred prior to the vaccination period. They have about 50% of their population vaccinated with 2 doses, but have been slammed really with multiple waves of infection. So they have fewer elderly people. So unlike us, where we have a higher proportion of elderly people, but they do have a very high risk population. So about 7 million people living with HIV, and only about 70% of them are on treatment. Next slide. So on the left here are countries who've been exposed to multiple prior waves of COVID over the course of the pandemic. And this is looking at deaths per million, so per capita. And you can see there on the top again, that's South Africa again. And we've got 4 other countries there. You can see that the declining lethality during the Omicron period. So this is just Omicron, and you can see with each wave that there's a declining lethality. Next slide. With children, so multi-system inflammatory condition in children, or PIMS-TS, otherwise known as in the US with their surveillance data. This is looking at MIS-C over time. The blue line, the dark blue line is the MIS-C cases, and the black dotted line is the COVID cases, so infection cases. And you can see again from the Omicron period, which is around December of last year, that things have declined with regard of the number of cases of PIMS-TS. And really since March or so, the cases have really declined very substantially altogether. And this has also been seen in the UK. If you can show the next, just click. In the UK, so the blue line there is the actual number of cases that have been observed, and the orange line or red line was the model which predicted what they would have anticipated given the rate of increase in the cases. However, that didn't occur, and so the number of cases has really gone away. So again, changes of property of the virus, with the different mutations that it had, but also the change of the host. So children have now, got vaccinated, not highly vaccinated in the UK, or in the US. So they've been vaccinated, but also have got infection-derived immunity as well. And that's also been seen in Australia too, with a declining number of PIMS-TS cases in the surveillance data. Next slide. So this is looking at cumulative deaths per million people since the beginning of the pandemic. And in the bottom right is Australia and many of the zero COVID countries. So really that waited for vaccination before they opened up. So Australia, South Korea, New Zealand, Japan, Singapore, all clumped down in the bottom there. So really have done certainly much better overall compared to other countries that had worse, in terms of control before vaccine was available. If you can click. And so really what we're looking at now is how for prior zero COVID countries, such as in the Western Pacific region, once they opened up to Omicron, is the immunity any different, or are things to be any different? Do we expect it to be any different compared to countries that have had repeated waves and repeated exposure? Next slide. So I showed this slide before. On the left, countries with multiple prior exposures, this is deaths per capita. And on the right, if you can click again, is the former naive country. So at the top is Australia. And again, this is deaths per capita. The second graph is New Zealand. And then we have Japan and Singapore, which seem to show that the peaks of deaths are sort of similar with each wave of Omicron, maybe less so for Singapore down in the bottom right. Next slide. And then this is excess mortality. So, there is some issues regarding the reporting regarding COVID deaths and COVID hospitalizations, etc. So if we look at instead the excess mortality from any cause, so this is what is is excess to what we would expect if COVID wasn't around. what are the deaths if COVID weren't around? So we can see this is from throughout the entire pandemic again in South Africa. On the left, you can see since Omicron, really there's been a decline again in excess mortality, which each wave, United Kingdom, a similar sort of pattern, and similar to Italy and probably France as well in terms of excess mortality declining over the Omicron period. Next slide. Now, in the UK, this is the only place that I know of that does random sample surveys where they look at cases and they sample the population every week that is representative of the population's demographics. So it's not biased to testing or who gets tested. It really tries to give a real representation of the cases by age and by region over time, and not is prone to that bias in testing of who comes forward for testing. So on the left here, you can see with the 4 different nations, this is in the last year, again, with the Omicron period, that cases are declining with each wave pretty much over time as well, and look to have already peaked with the current wave in the UK. Next, click again. So this is really at the peak of BA1, so in January, and this is by age. And you can see that the children in the top line and young adults had most of the infections, had the highest, with the age distribution were mostly infected, and the elderly in the bottom is had the fewer infections. The next one, click one more. And then this is the BA2 wave. You can see the young children, again, high infection rates, but again, coming up, slight change in age distribution. So the older people getting higher proportion of infection. And then click again. And this is the latest round of infection survey from the UK, showing a really different pattern. And it shows that the elderly are mostly being infected, and the young people, such as the children, have the lowest rates of infection. So this is really quite a different pattern that has evolved over time. So why is this happening? Next slide. So is it because there's higher waning in the elderly? Or less exposure, because of immunosenescence? Or could it also be because of hybrid immunity in younger age groups is more robust? And so they have better immune responses, whether to infection and vaccination, which persists for longer, and so therefore less waning. And so the graph on the right shows the age distribution, shows the age on the x-axis and the proportion of cases over the last 6 weeks in the UK. And you can see there, really it is shifted to the elderly, who are mostly getting infected at the moment, and less so, and children have got the lowest rates of infection at the moment. Next slide. In Singapore, the latest wave, which is now declining, increased over the last few weeks and is now declining, was mostly BA5 with the BA2 derivatives or lineages, and a little bit of BA4, but not much. Click again. And this is the proportion of cases who died by age and vaccination status. So the dark brown is the people who were not fully vaccinated, meaning that they hadn't had 3 doses of vaccine. And the x-axis is by age. So you can see that the vast majority of people who died were old, 80 or more, and there were a few who died who are less than 50. So vaccination status, so 3 doses of vaccine, and age were really the predictors of death. And then the next, click again. And this is those that required oxygen or ICU or died, and showing a very similar pattern. So really critical to have 3 doses of vaccination, particularly if you're over 50 years of age. Next slide. Now, this is Australia's current situation. So this is the deaths. On the left-hand side, we're now getting an increase in some of the subvariants at the moment. So that is expected to change. On the right-hand side, we have very high uptake of 3 doses of vaccine and less so of 4 doses, and particularly in the over 50s, but very high 2-dose coverage. We've also today released the seroprevalence survey. So in pediatrics, the seroprevalence survey found that over 60% of children up until August had been infected based on their antibody status. and it was about 70% in teenagers and about 61% even in children aged 1 to 4 who hadn't yet been exposed to any vaccination. So that's really all infection-derived, antibody. And then also in adults was also very similar prevalence, about 64% in adults, and showed that higher in young adults, up to 80%, and then down to about 62, I think, percent in younger, in the elderly. Next slide. In low and middle income countries, a different story. On the left there, we have Africa in pink, showing the share of the unvaccinated population. We've got Papua New Guinea, that's a standout, a number of Caribbean countries, Eastern European countries, and Afghanistan. Very poor access and uptake, or uptake in low and middle income countries with the booster, but also a lot of other priorities. So click. Again, there's measles outbreaks occurring now with the disruption of health services and immunisation. There's measles coverage is really low. The number of zero-dose children, so children that haven't received any vaccine at all, is about 18 million in the world. This is the highest on record that there's ever been, again, due to interruption of services. So, and there's measles and polio to be cautious about. And also the pneumococcal conjugate vaccine, a vaccine that's been around for 22 years, could save 1.7 million children's lives by 2030 if every country introduced it, but many countries haven't introduced it yet. And so really, and similar situation for rotavirus vaccine too, that many countries haven't even introduced it. So these are really priority countries, more so probably than COVID for children. Next slide. So really, I think this is my last slide. Niklas has already covered these things. Really, what are the outstanding questions related to hybrid immunity is really how many doses are needed, and by age group, for countries that are infected and with low country, but really have lots of multiple other priorities for immunisation and other health services as well. And it's the same health staff and the burnt out workforce that has to deliver, and how do they prioritise all of this? And then the timing and age groups for additional doses for vaccinated and infected populations like Europe and the Americas, but then in countries such as ours and that have been naive prior to Omicron, is there any difference? And do we have to be concerned about any difference in the epidemiology? So I'm going to finish there, and I'll hand over to Katie, who's going to look at the immunology. Thank you.
Thanks, Fiona. I will share my screen and get my talk up. And if you can just tell me if you can see that.
Yep, that looks great.
Lovely. Thanks, everybody. Well, thanks for inviting me to give this talk. And I'm going to try and do a little bit of the immunology and talk about hybrid immunity in the Australian context. As Fiona says, I'm a member of ATAGI. These are my views, not necessarily those of ATAGI. I thought I'd start with a few definitions. I think we all are aware that hybrid immunity refers to somebody who's actually had one or more doses of a COVID vaccine and at least one SARS-CoV-2 infection. There's another few definitions I thought I'd talk about. A lot of talk at the moment about immune imprinting, but I thought I'd just start with cross-reactivity. So cross-reactivity is where you get variants of a particular antigen, so in this case it'll be COVID, that can be recognized by the same B cell or antibody or T cell. And here you can see that you've got this little bit of the SARS-CoV-2 virus being recognized by this antibody. You've got a different one here, and it's been recognized by the same antibody. So that's true cross-reactivity. And that can also happen with T cells. So here we've got different clones of T cells, and they recognize different specificities. And then here you've got all four of these recognizing this one. So these are cross-reactive T cells. If you come in with this variant or get infected with it, you'll stimulate T cells against all these other ones as well. There's a concept called original antigenic sin, which has been around for a long time. And this is where both the antibodies and the T cell responses to any variant that you see don't stimulate responses to that variant. They stimulate responses to the very first infection you ever got. And this was first seen for influenza and is thought to potentially happen for COVID. And then there's the concept of immune imprinting, which is a little bit different because it's not against the original variant. It just means that when you get your antibodies, your T cell responses to a new antigen, you see a new antigen, a new variant, but it's very related and similar to what you've had in the past. It's the responses to the prior one that actually predominate. And so, for example, with COVID, that would be a predomination of the Wuhan strain responses when you see a variant. And that's illustrated in this diagram here, where you can see that you're getting the first vaccinations with this blue version of the spike protein, and you're getting boosted antibodies to the pale blue and the darker blue here, which is the RBD region and the rest of the spike protein. Then you get a boost with a variant antigen. Now this could be either infection or vaccination, but here the red variant area here, but boosting responses again to the dominant area where you've already got antibody responses and less of a response to the red. And then another one comes along here, which is yellow and variant. You get a boosting of responses to that yellow, but a much better boosting of responses to what you've already seen. And it's thought that this is likely to occur. And we know that many of the variants to which people will mount their initial immune responses are what are called immunodominant. So they dominate over some of those other responses. So what we do know in terms of vaccination and protection now against Omicron is that it will protect modestly and only for a short amount of time against symptomatic infection, asymptomatic infection, and viral shedding. But as we've heard in the previous talk, vaccination gives protection, very good protection against severe disease, hospitalization, and death. Not as good as infection and not as good as hybrid immunity, but does still provide good and sustained protection. And this protection is enhanced by boosters against Omicron as well. So that's in purely vaccinated people. In this study here, it's just confirming that by age group. And we said there, we heard earlier that there were some issues with looking by age, but in this particular study from Canada, which has just come out in preprint, they've looked at different age groups and looked at the effect of second, third, and fourth doses of vaccination and protection against severe disease. And you can see that it's still very good protection against severe disease across all age groups, even after 2 doses of vaccine, but that is improved by subsequent boosts. And the effectiveness, though, was in this study a little bit lower against BA.4/5 compared to BA.1/2. This study looked to see what a bivalent vaccine might do to your neutralizing antibody responses. And neutralizing antibodies are thought to be a surrogate of protection against getting COVID and severe disease. And the bit I just want to draw your attention to is the 2 bits on the right, where people have had either 4 doses of wild type vaccine, or they've had 3 doses of wild type vaccine followed by a BA.4/5 bivalent vaccine. And they looked at neutralizing antibodies across a whole range of different strains of SARS-CoV-2, including, of course, BA.4/5, and didn't find any difference when you had a bivalent vaccine on top of your first initial 3 doses, even against BA.4/5 itself. This was a very neat study published a little while ago in Science, where they followed various people who had different infection histories. So if you look on the left-hand side, we've got people that are naive throughout the whole of their primary course of vaccination and their booster. You've got some that got Wuhan infected right at the beginning and then had their 3 vaccines. Then others that got Alpha infected around the time of the first dose and Delta infected around the time of the second dose. They were then followed further to see what happened when they got Omicron infection or didn't get Omicron infection. So you've got some that remained naive. You've got others that were just Wuhan infected. Then you've got here somebody who got Omicron after having all their 3 vaccines, which is very similar to an Australian situation, or someone that had Wuhan followed by Omicron infection. And they were also able to look at Omicron infection in those that had Alpha and Beta. Now, there was a huge amount of analysis in this study, and I'm only going to mention a couple of sort of bullet points that came out of this. But they found that 3 vaccinations followed by an Omicron infection will actually preferentially induce immunity against the variants that you've seen before. So that would stand for the Wuhan infected or the other infected, rather than Omicron itself. And those actually that had Wuhan at the very beginning they had a completely ablated antibody and T cell responses to Omicron, which was quite concerning, I think, for many people. But don't forget, this is not protection. This is just antibodies that are being looked at. Their T cells were also a very different profile. And if they'd had alpha infection previously, then their Omicron responses didn't last as long. However, this study would go against that a little bit, because we're not seeing in this study complete ablation of responses to Omicron. So in this study, they had convalescent people who'd had COVID-19 from earlier strains and an infection-naive cohort. And then they had individuals that had been vaccinated and got Delta or Omicron infection after that. And they found that those with the Delta and the Omicron still had better neutralization to the other groups of people, including to Omicron. So they did stimulate responses to them. But they did find that an infection was not as good as the protection that you got from the combination of infection and vaccination. And I think everybody now understands that hybrid immunity seems to be the most superior thing that you can get in terms of protection. But the timing in this study was quite key, and the longer the actual timing between different exposures, be that infection or vaccination, the better the quality of both the neutralizing antibodies and how well they bind. And so basically this confirms that you can get Omicron immunity when you get an Omicron infection on the background of anything that you've had in the past, and that hybrid immunity is superior. So the data that we heard earlier was about from the pre-Omicron era. So I'm trying to just present some of the data around Omicron and anything special about that in terms of hybrid immunity. In this particular study, they had mRNA vaccinated people, and they looked at people who had a BA.1 Omicron breakthrough infection. And what they definitely showed was that there was a lot of cross-reactivity, and most of the response was due to cross-reactive antibodies to prior infections that had been seen and prior strains. But those B cells, memory B cells that sit in the lymph nodes, over time, they actually mutated and evolved, so they became broader and more potent at inducing antibodies. So even though you get a lot of cross-reactive responses from prior variants that you've seen, you do still get a broader immunity developing over time. And in this study, just a small study in a small group of people, but in this one, they actually took blood and lymph nodes and bone marrow aspirates in people that they'd aspirated, that they'd vaccinated. So these people were COVID naive at the beginning, like in Australia, and then they had their original mRNA vaccines, and then they were boosted with either just the original vaccine or a betavalent or one of the Omicron bivalent vaccines. And again, they showed very marked immune imprinting. So many cross-reactive antibodies are recognizing the original Wuhan strain, which fits with that pattern and that diagram that I showed you. But many of them were cross-reactive against other strains as well. But because they had the bone marrow and they had the lymph nodes, they were able to have a very careful look at the B cells and what was happening. And they did find that Omicron-specific B cells were generated from naive B cells, even though you had a lot of memory B cells that were also stimulated at the same time. So definitely the Omicron vaccines and other vaccines can overcome immune imprinting, even if immune imprinting is a concern. And in this study, we're just... These next three slides just show how hybrid immunity protects against Omicron infection, because we haven't actually been able to see Omicron data in the previous studies. So we've got Pfizer vaccinated and Moderna vaccinated people here with symptomatic disease or severe disease. And what you can see is that certainly against severe disease, as we heard earlier, 2 doses and previous infection, and 3 doses of vaccine or 3 doses and previous infection all seem to give extremely good protection against getting severe disease. And 2 doses of vaccine and prior infection doesn't seem to be any worse than having 3 doses. So that seems to give very robust immunity, which we can see has seen in previous slides from Niklas that probably they would last about at least a year. Against symptomatic infection, it's not quite as good, and the superior thing would be to have 3 doses of vaccine and previous infection. Likewise here, same thing. We're seeing that basically if you have previous Omicron infection, rather than and you've been vaccinated with either 3 doses or 2 doses of vaccine, you've got very, very robust infection. So again, showing very much the same thing. Once you've had 2 doses of vaccine and an Omicron infection, or 2 doses of vaccine and any other infection, then you actually have much better protection than somebody who has not had an infection. So hybrid immunity certainly working better than vaccination alone, which is this group here. And again, limited benefit from that 3rd vaccine dose. And finally, just this was a study that's very recently published, just showing protection against BA5, which of course we're all concerned about at the moment. This is a study from Portugal, a very highly vaccinated population. Many were vaccinated prior to previous strains, but as we know in Portugal, they did have some various waves, but particularly their main waves still have been from Omicron. And what they found here is that the BA1 or BA2 infection in people that have been previously vaccinated gave the greatest protection against BA5. So although those earlier studies were suggesting Omicron infection does not protect against subsequent Omicron, or suggested that antibodies and T-cell responses are ablated, it seems that they do still provide clinical protection if you actually get an Omicron infection after you've been vaccinated. This is another study that's just come out in preprint, which is interesting, but I think should be interpreted with caution. It's from Qatar, and in that population, it's a very young population. They did a 6-month follow-up, and they looked at people during the Omicron era. They compared the unvaccinated and the 2-dose and the 3-dose people. And these are people that had already had either no vaccine or they'd had 1 or 2 or 3 doses, and then they got Omicron. And then how did that protect them against getting Omicron again? And if you look at the top graph here, you can see that the 2-dose cohort was much more less likely to get infection. This is the cumulative infection, reinfection incidence as compared to an unvaccinated cohort. But what they've shown in the bottom graph is that the 3-dose cohort was more likely than the 2-dose cohort to get a second infection. And that suggests that that first Omicron infection imprinted immune response that diverted away and actually prevented them from being as well protected as someone has had 2 doses of the vaccine. And one of the things they suggest here is that those 2 doses that people had in their primary vaccination were generally 3 to 4 weeks apart, as in Australia. And then that's almost like just seeing that variant once. And so often it's your first few doses, your prime and your boost, that really lay down your immunity. But as I said, interpret this one with caution, because there were many confounders in this study that I think really weren't accounted for. But just to conclude, Omicron infection or vaccination does stimulate immunity to the prior variants, and that could either be an immune imprinting or cross-reactivity, or a combination of the two. But I've shown you that Omicron infection can definitely stimulate new Omicron-specific B cells, and also that stands for T cells as well, and antibodies against it, even if the original strain responses do tend to predominate. And I think that the data I'm showing you suggests that Omicron-specific vaccines may not really be clinically superior to the original vaccines in people that have been prior vaccinated and infected. Definitely hybrid immunity seems to be the best thing of all. And it's more obvious for the any infection or symptomatic infection, because all things seem to protect quite well against severe disease, hospitalization and death. So prior infection or vaccination are all highly effective and have long-term protection against the severe outcomes. Hybrid immunity from 3 vaccine doses followed by Omicron infection seems to offer little additional benefit over 2 doses of vaccine and then infection. And that last study I showed suggested it may even be deleterious. Having said that, we know that prior BA1 or 2 infection gives the best clinical protection against BA5. So I think it's really hard to draw definite conclusions at the moment, but it seems to me that hybrid immunity is fantastic, boosting does work, and that if you do have a prior infection with Omicron, you definitely can get Omicron protection. So what does this mean for Australia? As Fiona said, we have a very high vaccination rates, and we vaccinated a predominantly naive population who now have developed hybrid immunity from very high rates of post-vaccination Omicron infection. So essentially, I guess the horse has bolted in a way in terms of what we can do, because our immune memory has been laid down and we've really got to work with what we've got now. And what we do know is that if you do boost against this, then you should be able to get immunity against future variants. I think by having vaccinated a broadly naive population, we've probably overcome some of those very early immune imprinting effects that we saw in that study, where we saw if you had a Wuhan infection at the beginning, you really didn't respond that well to Omicron later on. And triple or quadruple vaccinated followed by Omicron infection seem to have less long-term protection against Omicron than the 2-dose groups. So in terms of where we're at, so we've got fully vaccinated, or many fully vaccinated with more than 2 doses in the adults. With they should really have very good sustained protection against severe disease and death, particularly because so many of them have had Omicron infection. But I think if we do need to give further boosting, that should give good protection against Omicron. If we think about our young children, if you are either fully vaccinated or even had 1 dose and then an Omicron infection, I would say that would give very good and sustained protection against severe outcomes. And let's face it, these children were never really very susceptible to severe outcomes in the first place. And it's possible they might even be better protected than the boosted adults anyway. So I think for children, there's probably little value at the moment in offering boosters. And I guess looking into the future, I think it's hard to know, but I think the predictions would be that the current vaccines will provide reasonable protection against future variants that haven't even emerged yet, although they're starting to come, and that we'll see if it's actually borne out to be true. But I think that the protection against severe disease and death should last for a good 12 months at least. And then that will make us decide when we might consider actually boosting. The more closely related a variant is to which an individual has been exposed, you would imagine, and the more recent that exposure, then the better the protection should be. And we know that boosters do work. And I guess in the future, there will be a requirement for intermittent boosters. And let's hope in the end it's not any more than annual. And that was what Niklas was suggesting, that annual may well be sufficient, even for those that are more vulnerable. And I guess we've got to decide what we want to do in the future anyway, because as Fiona says, deaths are going down, severe disease is going down. And that's probably also partly to do with the adaptation of the virus, but also adaptation of the population. And I don't think chasing variants with variant vaccines is going to be a practical or even necessary approach going forward. And I guess we have to remember there are still hundreds of vaccines, COVID vaccines in the pipeline, and many of them are being designed to specifically overcome these immune imprinting effects by really focusing on epitopes that are going to be boosted and not overshadowed by those other responses, and trying to get local mucosal immunity as well. So I shall stop there. And
well, thank you very much for that, Katie. We've still got a few minutes for questions. The first one, I'll have a quick answer. Nigel Curtis: is diminishing lethality in each wave also partially explained by the virus already having killed a proportion of the most vulnerable in each of the previous waves? I had a quick Google of that, Nigel, while Katie was talking. And in the UK, for example, there's 3.2 million people aged over 80. And in total, there's been about 200,000 deaths, mainly in the elderly. So that's about 7% of the population of people over 80. So it's probably more likely related to a combination, obviously, of vaccination, hybrid immunity, and access to antivirals. But knowing that a lot of the world doesn't have actual access to antivirals as well. So probably less so than, that people who have, because age is such a big risk factor. Katie, I'll ask you this one from Joe Fogarty. Is there any data on risk of long COVID following infection in those with hybrid immunity or vaccine-induced immunity?
Yeah, there's definitely data on vaccine-induced immunity, and that does show protection against long COVID. I haven't seen anything that talks about hybrid immunity. But of course, once you have hybrid immunity, that means you've actually had an infection, and we know that definitely vaccination is protecting to some extent against it. Not only that, but also vaccination seems to, in some cases, there's suggestions, reverse or cure or treat long COVID, so actually give you some level of recovery from it. But as you'll be well aware, it's still so uncertain exactly what is driving long COVID. And I don't think it's a single syndrome. It's actually a whole combination of things, sort of altered immune homeostasis and also a lot of auto antibodies being switched on by either infection, well, mainly infection. Yeah.
Thank you for that. Kim Mulholland, I'll give this to you, Niklas. Is there any data indicating whether vaccine followed by infection is better or worse than infection first followed by vaccine? So I'm thinking, in particular, that's in our context, I guess. We were naive and then we got vaccinated. So maybe Niklas on the data that and then I'll check then to you, Katie.
Yeah, that's a great question. So we have some data on that, but we haven't run the analysis yet. As I mentioned, there's a bit of, there's so many combinations of the data. So, partial primary series, full primary series, like the number of doses and also the number of infections has led to sort of a scattering of the data. We haven't run the analysis yet, so I can't answer the question, but it's something that we're looking for.
Right. And I guess I'd say that science paper by Rose Boyton and others does show that there is a difference if you get your infection first, whereas compared to getting your infection at the end. But some of what they've described doesn't necessarily seem to be borne out in the data that are coming out from other studies. But there they were showing that if you had your Wuhan strain infection at the beginning and then you were vaccinated, you had completely ablated responses to Omicron, both T cells and B cells. Whereas if you were naive and then had your vaccines and then had a Wuhan infection, you didn't have such a problem with actually generating immunity to it. And prior alpha infection altered the durability of those responses to Omicron as well. So there definitely does seem to be an effect of when you got your infection and the order in which things have occurred. But there are so many variables, as Niklas said, because severity of infection will actually impact what your immune response is like and the quality and the durability of the antibodies you get, which vaccine you get, which order you get it in, and also the spreading of those vaccines. Because I think at the beginning of all of this, we were giving these vaccines very close together. And in fact, spreading it out, as Atagi have gradually made recommendations to actually give them further apart, clearly gives more durable and better immunity. So it's a very complicated situation because so many people have had so many different patterns of infection and vaccination. And of course, many people would have had asymptomatic infection as well and not even known that they'd had an infection somewhere in the piece.
Right. It is 2:30, but we'll keep going with questions as long as we don't get cut off. But if we do get cut off, thank you very much to Katie and Niklas and for Audrey for organising, but we'll keep going. Katie, this is probably another immunological question. Why is protection worse following an Omicron infection in those who previously had 3 or 4 vaccines compared with 2? So I guess that's the Qatar study, probably.
Yeah. So what I think they're trying to say is people have had 2 vaccinations. The suggestion is those vaccines were given very close together. And it's almost like a single priming event if you just have them a few weeks apart. And then your second exposure is the actual infection. And so you haven't laid down as much immunity, and you can get better and sort of more robust immunity to that second heterologous boost that you're actually getting. Whereas if you've had 3 doses or 4 doses, you've laid down very good firm immunity and boosted it to what you had originally, and then you don't respond as well to the Omicron. That's the sort of theory behind it. I think it'll be interesting to see how this plays out as time goes on. But there's no doubt every study that's trying to really investigate immune imprinting and or cross-reactivity is showing that it's very, very prevalent. And really, when you get another infection, you still boost up an awful lot of what you've had before through cross-reactivity and immune imprinting.
I also wonder, Katie, I haven't read that. I know it's a preprint, that Qatar study, but I don't know whether they go over who's actually getting tested. So if there's any difference between who gets tested, if you've had 2 doses or 3 or 4 doses, that could really skew those results too, because you would imagine that people that have had 3 or 4 doses are more likely to have comorbidities or transplants or whatever, who are going to be testing more and also prone to having, you know, bad outcomes as well. So I haven't read that study, but, you know, in terms of, you mentioned the confounders, but
I think it needs to be interpreted with caution. This is a very young population as well, young and healthy. There were no severe disease in there at all, and they were expecting to analyze for that, but no deaths, no really severe disease. So I think it's hard to really interpret, and it's based on, they say that they've got fantastic national database, and every test done, they've got all the details on rats and PCRs and everything. But you're right, I mean, people don't always come forward, and you don't know whether people have had asymptomatic infection. So my read of that paper is it's a little premature to make those kind of conclusions. And what's very clear from many of the studies I see, you get a booster, you definitely boost up a response, and that will boost your protection against severe disease and death if you're highly susceptible, and it will, even if you're not highly susceptible, and it will give you some protection against actually symptomatic infection for a good 3 months or so. So it's a really good tool to have, and I think even against Wuhan or future variants, it's a good tool to have there if we are faced with a situation where we need to be protecting certain people in the population as immunity wanes. And of course, we are, I'm sure, going to have to be recommending boosters in the future. And right now we're looking at this window, but what's the future look like? So COVID isn't going away, and we'll have to have a strategy which will be a sort of, you know, business as usual type strategy once the pandemic has settled itself down into some kind of predictable patterns.
I think you've already answered this, but why children under 15 who have not been infected should not have a booster now? I mean, we know the risk of severe disease in that age group is very low. The pediatric data came out today from the seroprevalence survey, which showed that 80% of teenagers, 70% of teenagers have already been infected, and 60% of 1 to 4-year-olds, and, you know, primary school kids. So I don't know if you want to add anything to that further, Katie.
Yeah, look, I mean, if they've not been vaccinated at all, they're going to have fairly good protection if they've had an infection. They are not high risk for severe outcomes, and I think it really depends on what you're trying to protect against. And a lot of the program in Australia has been about, you know, keeping the country running, protecting against severe outcomes, hospitalization and death, not crippling our hospitals with COVID patients. And so that group is not the group that is presenting in that way. As you say, the MIS-C levels are going down. I mean, long COVID is always a concern, but once they've actually had their COVID, then, and they haven't developed it, then they're going to have quite sustained protection against any severe outcomes in the future. So maybe, you know, with the way that we are now in Australia, it's time to just recommend that anyone that isn't boosted, that should be boosted and has already had their recommended boosters, has not taken up their recommended boosters because they have increased susceptibility, I think they should be looking to get the boosters, particularly since we are now in a new wave, and we know that we've got some new variants that are likely to come up very quickly in Australia. But if you look at the data that you showed from around the world, and certainly from Singapore, it was all over within about 4 weeks or so, and very few hospitalizations or severe disease and death, definitely hospitalizations, but not severe disease and death. So I guess we're less worried about those younger people at the moment, and perhaps now's the time just to watch and wait and see what happens. But if they had 2 doses and they've had an infection, we know that will give them very long and sustained immunity, but probably 1 dose and infection as well would do very much the same.
Yeah, I think no problem. So, and high-risk children always, there's a booster available for high-risk children.
Yeah,
so
that's a different scenario.
different
I think
scenario.
so.
Yeah. The question was about children who have not been infected, but I think the issue is that, and again from the seroprevalence survey that came out today, many children are asymptomatic. So in that survey, they asked the parents whether their children had ever been infected, and there was a high proportion that tested positive, but the parents had reported they hadn't been infected. So you can't tell, and nobody's going to test. So you just wouldn't, it's not a clinical scenario that is a reliable one. So, so yeah. The other question is immune imprinting and antigenic sin. Are they the same thing? Again,
no, no. As I said at the very beginning, they're very similar. Original antigenic sin is really to the very first thing you see, and it almost cripples your immune system so it cannot respond to other variants. It just boosts up immunity to what you've seen in the past. Whereas immune imprinting is more that you're boosting up a range of responses, and you can still get new responses to the new variants, but you tend to have the previous antibody responses or T-cell responses boosted up predominantly. So they're not the same thing exactly, no, but they're very similar, and it's a similar concept.
Right, and I think we'll have the last question. Well, we weren't talking about long COVID today, but Katie, if you're happy to answer it, the relationship between severity of infection and likelihood of long COVID.
But my understanding is it's not necessarily related to the severity of infection, actually. And now what the reason for that is, I can't really say. But I mean, there are data emerging showing how COVID can stimulate multiple different autoantibodies and different immune profiles, and can also cause prolonged immune activation, like I was saying earlier. So I don't think it's a dose-related or severity-related problem. I think it's an immunological set point problem, and different people behave in different ways and can go down that trajectory that leads to them developing long COVID. I think we're a long way from understanding exactly what long COVID is, but it doesn't seem to be a single entity. If you think about the neurological or the neuromuscular or the cardiovascular outcomes that people have, they're all quite different, and it's a whole array of symptoms that different people come with. And I look forward to us understanding it better.
No worries. I think we'll leave it there. Thank you so much, Niklas and Katie, for your time today. I found it very informative, so I hope the audience did too. We'll have this has been recorded, so we'll put it up on the website later on. Thank you very much to Audrey and for organising this as well, and have a great afternoon. Thank you.
Thanks, Fiona.
Bye.
Thank you.
Bye.